This presentation constitutes the rest of Chapter 13 and will finish up Module 1. In Module 2, we'll be looking at some virulence factors of microbes, and it's introduced in this chapter to a small extent. So I'll talk about it here a little, and then when we get to Module 2 in much more detail. I mentioned before that microorganisms have to have a mechanism by which they can attach to surfaces because there's typically some type of a fluid that washes over those surfaces that would wash the microbe away. In Module 2, we'll see a number of different tactics that microorganisms can use, but you've already learned about fimbriae. Fimbriae are short, bristle-like structures, and Neisseria gonorrhea, for example, will produce these fimbriae that allow them to attach to not only the genital epithelium, but also to sperm, so they can hitch a ride up into the pelvis of the female and can cause pelvic inflammatory disease. And there are a number of other mechanisms that you can see here that allow organisms to attach to their host. Of course, being able to survive the host defenses is going to give a pathogen an opportunity to survive. So the initial response of host defenses comes from phagocytes. When we are presented with invading microorganisms, our white blood cells will be one of the first that comes to call. Some microorganisms produce antiphagocytic factors. Remember, they've been around for a long time, so they have evolved mechanisms to escape from white blood cells. Sometimes they can kill the white blood cell. They produce leukocidins. Other times they're little Houdinis, and they can escape from the vacuoles inside of the phagocytes. And others actually evade phagocytosis just from the get-go. In lab today that you saw Klebsiella pneumoniae, and it has a nice thick capsule around it. That makes it difficult for white blood cells to engulf the microorganism because they're said to be slippery, so the white blood cell just sort of slides right off. Some organisms do get inside of the cells, not all of them, but most of them are going to have some type of a mechanism where they produce toxins or going to damage host cells, but sometimes they will actually get in. Here's an example of a secretion system produced by certain bacteria, and we'll look at it in more detail in Module 2. We see this with Salmonella. We also see it with Escherichia, and we can see here that the organism commands the cell to engulf it. So the cell that normally does not act like a phagocyte will act as a phagocyte and will bring the cell into the vacuole. Once the cell, in this case you see Salmonella, once it multiplies, once it gets into the cell, it starts to multiply internally. Sometimes it can get out of the cell, and we're looking at an epithelial cell of the intestines right now. Sometimes it can get out of the cell and it can go into deeper tissues, causing septicemia, for example. The virulence factors are those traits that are used to invade and establish themselves in the host, and it also can determine the degree of tissue damage that occurs. Bacteria can produce a whole host of enzymes. Some of them are produced intracellularly and exported. We call those exoenzymes. Some of those enzymes are actually part of the microorganism. Many microorganisms exert their pathogenicity by producing toxins. There are two types of bacterial toxins: endotoxins, which are actually part of the bacterial cell, and we'll see more about the gram-negative cell wall and the lipopolysaccharide in Module 2 and look more at the effects of endotoxin on the human body. Exotoxins are toxins that are created inside of the cell, but then they are secreted. And they typically are going to have a specificity for a target cell. Endotoxin is going to have a generalized effect, whereas exotoxins are going to be much more specific. A hemolysin is a toxin that breaks open red blood cells, and then there are toxins called AB toxins. So here you can see with exotoxins, specific organs are going to be damaged. It may end up targeting the central nervous system or targeting the circulatory system, such as the heart. And you also can see endotoxins. Endotoxins just have general physiological effects. They cause things like fever, malaise, aches, and shock. It can be very serious, and in fact in Module 2 we'll see some of the more deleterious things that endotoxins can do. All gram-negative bacteria produce endotoxins. So here is a table that shows you differences and similarities in exotoxins and endotoxins. So as far as exotoxins, it doesn't take very much of the toxin in order to cause an effect. We'll take a look at some endotoxins in Chapter 2 that are the most toxic molecules known to man, for example, Botox, botulinum toxin. For endotoxin, it takes a lot more of the toxin in order to exert its effect. Exotoxins are specific to a cell type, whereas endotoxins are systemic. Exotoxins tend to be small proteins, but endotoxins are lipopolysaccharides. Toxoid formation, this means can we make a vaccine out of it? So exotoxins can be converted to a toxoid and then can be injected as a vaccinating material. An example for that would be diphtheria. Another example would be tetanus. Endotoxins cannot be converted to toxoids. Toxoids typically are made by precipitating them with a chemical called alum. The immune response we see to exotoxins is the production of antibodies to these toxins, and we call them antitoxins. Endotoxin does not stimulate antibodies. Usually with exotoxins we don't see fevers, but with endotoxin we do see a fever. Exotoxins are secreted from a cell, but endotoxins are not released from a bacterial cell until it dies. Typical sources for exotoxins, we see a few gram-positive and gram-negative cells, but with endotoxin, all gram-negative bacteria will produce that. And there's some examples here. Tetanus, diphtheria, cholera, and anthrax are all produced by the effect of toxins on the body. Exotoxin specifically. Endotoxin we can see causing endotoxic shock. We also see endotoxin being released in salmonella, systemic infection, and also in meningitis. AB toxins, again, we'll look at a little more in Module 2. AB toxins have two components. The A, which is the active component, is attached to the B, the binding component. The A component inhibits a cellular response to cause the damage to the host cell. So here we have a video we can listen to. Start it over again.
AB toxins are proteins that consist of two parts, A and B. The A portion is an enzyme that constitutes the toxic part. The B portion binds to host cell receptors. There are several mechanisms by which AB toxins enter the cell. One mechanism involves the uptake of the toxin after binding by endocytosis. After endocytosis, the contents of the vacuole become acidic, causing the A and B portions to separate. The A portion enters the cytoplasm of the cell and exerts its toxic effect, while the B portion is removed from the cell by exocytosis. Different microorganisms produce A toxins with different activities. The A toxin produced by Corynebacterium diphtheriae carries out the transfer of ADP ribose to elongation factor 2, EF2, and thereby inhibits protein synthesis. ADP ribosylation is a common action of AB toxins.
So the last part of this chapter takes a look at the process of infection and disease. And when a person gets sick, we see 4 distinct stages of clinical infections. And we're talking now about bacterial, viral infections, protozoan infections. And the first part of the infection will be the incubation period. This is the time from the initial contact with the infectious agent to the appearance of the first symptoms. The agent is multiplying, but damage is insufficient to cause symptoms. This can take several hours to several years, depending upon the microorganism that we're talking about. In the prodromal stage, now we get that feeling that, oh man, I'm getting sick. So you have these vague feelings of discomfort, non-specific complaints, and now the organism enters into the tissues, or it actually is multiplying at high levels, producing toxins. It is becoming well established, and we see much more specific signs and symptoms. At the height of the infection, then, we see microorganisms dying off as long as the immune system is intact or there is some type of an intervention, for example, taking an antibiotic. And we see the final period of the disease then called the convalescent period. As a person begins to respond to the infections, the symptoms are going to decline. So we see this graph here showing the incubation period, the prodromal stage, the period of invasion, and then the convalescent period. And we'll see later that this mimics the graph that we see with the growth of a microorganism in culture. Patterns of infection, we can see an infection being localized. The microbes enter the body and they remain confined to a specific tissue. For example, we could see a carbuncle or a boil on the skin and it remains localized. When the infection spreads to several sites and tissue fluids, usually in the bloodstream, we see a systemic infection. We can also see a focal infection, and this is when an infectious agent breaks loose from a local infection and gets carried to other tissues. So, for example, a localized infection can begin as a boil with Staphylococcus aureus, and then Staphylococcus aureus can get into the deeper tissues from that local infection, be carried to other tissues. If it is then spread through the bloodstream to other body parts, this can then become a systemic infection. A mixed infection is called polymicrobial. This is not that common. Mixed infections usually are seen in those that have a compromised immune system. Typically when we see pneumonia, if we see septicemia, if we see a urinary tract infection, it's a single microbe. It's not polymicrobial. The first infection that we see is called the primary infection, and then we can see secondary infections. For example, a person may have chickenpox, and the chickenpox would be the primary infection. The pustules are then open to the environment, and let's say a Staphylococcus aureus gets in there, it causes a skin infection that we would call a secondary infection. So this is another infection by a different microbe. An acute infection comes on like gangbusters with severe but short-lived effects, whereas chronic infections progress and persist over a long period of time. An acute infection actually can be seen followed by a chronic infection. So a person may exhibit the signs and symptoms of an acute infection, and then the microbe might become established, for example, in tuberculosis or in hepatitis, the hepatitis B. The microorganism or virus can remain in the tissues for a longer period of time and exert their effects in a chronic infection. Signs and symptoms are two different things, and it's a good idea to understand the difference between the two. Signs can be measured and symptoms have to be explained. So signs, for example, that can be measured. A thermometer could measure a fever. Septicemia could be measured by doing a blood culture. We could use a microscope to see microbes in tissue fluids. Skin eruptions are going to be something we can see. Leukocytosis, an increase in white blood cells, and leukopenia, a decrease in white blood cells, can be seen by doing a complete blood count and a differential. Abscesses can be seen, and an increased heart rate can be heard. Antibodies and serum can be tested for. Symptoms have to be explained. So shaking, for example, would be a sign, but chills would have to be explained by the person. Pain, is usually rated on a scale from 1 to 10. Nausea is a symptom, whereas vomiting is a sign. Malaise, which is fatigue, is a symptom. Chest tightness, itching, headache, weakness, they all can't be measured, so they have to be described by the patient. Anorexia or lack of appetite would be a symptom described by the patient, and a sore throat would be a symptom as well. The earliest symptoms of a disease as a result of the activation of the body defenses will be the signs and symptoms of inflammation. So when one becomes infected with a microorganism, there are a few signs that we can see of inflammation. One is an accumulation of fluid that's called edema. So we can see that with something like cellulitis. Granulomas and abscesses are walled-off collections of inflammatory cells and microbes. Inflammatory cells we're talking about there are white blood cells, and abscesses and granulomas can be visualized on the skin. Lymphadenitis is when the lymph nodes have been activated. They're doing what they're supposed to do, clearing out microorganisms, but they become swollen in the process, and often we'll see lymphadenitis in the around the throat area, and we can also see that in the armpits and sometimes in the groin when there is an infection. We also can see the changes in numbers of circulating white blood cells. Leukocytosis is an increase in white blood cells, and leukopenia is a decrease in white blood cells. This is often useful when diagnosing things like pneumonia. Bacterial pneumonia, we would actually see a leukocytosis, where a viral pneumonia, we often see a leukopenia. Septicemia is when microorganisms are multiplying in the blood and present in large numbers. It's bacteremia if they are present in blood but not necessarily multiplying. For example, there may be bacteria in the lungs during pneumonia, and those bacteria often take a run for it in the bloodstream. You might have heard a physician ask for blood cultures to be drawn when a patient's temperature spikes. When a temperature spikes, that's usually when the bacteria are running through the blood as bacteremia, so not necessarily septicemia. The microorganisms aren't multiplying, but they are in the blood, and sometimes we can catch them with a blood culture. That might help us to diagnose pneumonia. It's difficult to diagnose pneumonia. Viremia is a small number of viruses present in the blood, not necessarily multiplying. So as far as HIV/AIDS, the virus is going to multiply in white blood cells and other immune cells, and we see very low viral loads, as we call them. We don't see much virus in the blood. The aim of triple cocktail treatment of HIV today is to reduce the viremia, or the viral load, to zero. An infection that goes unnoticed is called asymptomatic. Another term we use is subclinical, and although infected, the host doesn't show any signs of disease. This can be problematic because it isn't apparent, so the person may not seek medical attention. Of course, pathogens have a portal of entry, but then they have to get out. So the portal of exit is often the same as the portal of exit. The respiratory portal, when you contract a cold, for example, the virus is going to get in through the respiratory tract. It's going to come out through the respiratory tract. You can also shed skin. Microorganisms can exit through the feces. Microorganisms can exit through the urogenital tract, through the urine, or through vaginal fluids or semen, and also removal of blood. So blood is a portal of exit as well. Just because a person has recovered doesn't mean the microbe has been removed. There are cases that we call latency. After the initial symptoms in certain chronic diseases, the microbe can periodically become active and produce a recurrent disease. The person may or may not shed it during the latent stage. One of the best examples of latency is with the herpes virus. So herpes virus 1 and herpes virus 2 we'll look at in Module 5, and these viruses are latent and they remain quiet, but periodically they can surface. There are a number of drugs that can be used to prevent that from happening. A chronic carrier, an example was Mary Mallon. That's a person with a latent infection who sheds the infectious agent. So Mary Mallon had typhoid fever, and she infected some of her employers' children with the Salmonella typhi organism. Sequelae are what we call long-term or permanent damage to tissues or organs. Rheumatic fever has a number of sequelae. Rheumatic fever is caused by Streptococcus pyogenes, and Strep pyogenes causes strep throat, and strep throat can lead to some very serious sequelae, including heart damage and kidney damage, if it is not treated. Nosocomial infections are diseases that are acquired or developed during a hospital stay. It can also be during a nursing home stay, so it's not limited to hospitals. It's any type of a healthcare situation. It's pretty clear how easy this would be to happen. You get this from surgical procedures, from equipment, from personnel, and exposure to drug-resistant microorganisms. Excuse me. Drug-resistant microorganisms proliferate in the hospital. Really, the hospital is the worst place to be if you're sick. So you can see here, there are 2 to 4 million cases per year in the United States. Approximately 90,000 people die from nosocomial infection, so this is a very serious problem. Very many from the urinary tract, organisms that are listed there we'll talk about in Module 5. Urinary tract infections are common because of catheterizations. Lower respiratory tract due to intubations. Surgical wounds, of course, entering the body through any route is going to let microorganisms come in. Skin and blood infections, of course, are going to be common after intubations or after surgery. So it's a very serious problem. We're going to talk about drug resistance in Module 4. There are a number of means of preventing nosocomial infections, and if you are going into nursing or a medical field, you'll learn more about these. Enteric precautions are those that we take with people who have diarrhea, rotavirus, for example, Giardia. Respiratory precautions we would take with people that have tuberculosis and things that are spread through the respiratory route, such as measles, mumps, meningitis, pertussis, rubella, and chickenpox. Drainage and secretion precautions would be post-surgery. Those individuals that perhaps have staph infections or strep infections, gas gangrene caused by Clostridium, herpes zoster, and also burn infections. Often in cases like this, we are trying to protect the patient instead of the person who is visiting the room or the nurse. Strict isolation, of course, is going to protect both the patient and the people coming into the room. These are for the most highly virulent or contagious microorganisms, extensive skin and burn infections. In that case, the patient would be highly vulnerable from burn. Burned skin is easily infected, herpes simplex, and zoster, which is shingles. Reverse isolation or protective isolation is done primarily to protect the patients, and it's protecting those patients that are extremely immunocompromised. Perhaps they have HIV, they've had surgery, there's a genetic defect, or they are undergoing cancer chemotherapy. Universal blood and body fluid precautions were developed by the CDC, and they are stringent measures to prevent the spread of nosocomial infection from patient to patient, from patient to worker, and from worker to patient. We call these universal precautions. Many of the things that you will be learning in microbiology, aseptic technique, for example, will translate into universal precautions. We always assume that all patient specimens harbor infectious agents. So every patient specimen, whether it's a urine, a sputum, a skin swabbing, we treat it with the same degree of care using universal precautions.